Hi everyone, welcome to part 2 of the Intro to EKG video. So in part 1, we discussed the basics of the EKG, and now in part 2, we will begin to discuss how to interpret the EKG. Interpreting the EKG can be broken down into looking at its rate, rhythm, axis, PR interval, QRS complex, QT interval, ST segment, and T wave. The rate of an EKG is referring to the ventricular rate or how fast the ventricles are beating. One of the ways to determine ventricular rate on the EKG is by counting the number of boxes between the heartbeats. The x-axis of the EKG paper represents time, and each of these tiny boxes is 0.04 seconds or 40 milliseconds. A big box, which is 5 of those tiny boxes, is 0.2 seconds or 200 milliseconds. But ain't nobody got time for that. So a quicker way to approximate the ventricular rate is to count the number of heartbeats on the EKG and multiply it by 6. The EKG we typically see in the ED is of a 10-second run. So multiplying it by 6 gives us the number of beats per minute. But ain't nobody got time for that either. If you want to be like a normal human being, you can just look at the top left corner of the EKG and see what the EKG machine determined to be the ventricular rate. In this case, it's 56 beats per minute, which is pretty close to our approximation of 54 beats per minute from earlier. Most of the time, the EKG machine does a pretty good job of calculating the ventricular rate correctly. Normal resting heart rate is somewhere between 60 and 70 beats per minute for most people. Bradycardia is a slow heart rate where the heart is beating less than 60 beats per minute, and tachycardia is a fast heart rate where the heart rate is beating greater than 100 beats per minute. If the heart beats too slowly, it won't be able to deliver the blood and oxygen that the body requires, but when the heart beats too quickly, what can happen is that the ventricles will contract before they've had the time to fill up with blood. So while the heart may be beating very quickly, little or very little blood is actually being pumped out. Again, the body won't receive the blood and oxygen that it needs, and patients will begin to exhibit various symptoms. To summarize rate, it can simply be broken down to, is it slow, is it fast, or is it normal? So that's rate. Let's move on to rhythm, where we will spend most of our time today. While the heart can beat in many different rhythms, we will focus on some of the more common ones, including normal sinus rhythm, atrial fibrillation, atrial tachycardia, atrial flutter, supraventricular tachycardia, premature atrial contractions, premature ventricular contractions, ventricular tachycardia, and ventricular fibrillation. By and large, irregular rhythms or arrhythmias can be classified by whether they're originating from above the ventricles or from within the ventricles. We're also going to focus mainly on the EKG findings of these rhythms and not delve too much into their clinical manifestations or treatments. Let's start with NSR or normal sinus rhythm. The term sinus refers to the fact that the heartbeat was initiated by the impulse that originated from the SA node and denotes a normal heart rhythm. On the EKG, this is seen as presence of the P wave followed by a QRS complex. So whenever you see P waves, it will be a sinus rhythm. When an EKG is described as having a regular rhythm, this is referring to the fact that there are even spacing between the heartbeats. With any rhythm, the rate can vary, and when you have a sinus rhythm with a heart rate that's below 60 beats per minute, you have what's called sinus bradycardia. If the heart rate is greater than 100, you will have what's called sinus tachycardia. The EKG paper sizing for both of these are the same, and just by glancing at the two, you can tell that the heart is beating a lot quicker in the bottom EKG than the top EKG. In both of these examples, the P waves are identifiable, which makes them examples of sinus rhythms. If the patient has a dysfunction somewhere along their conduction system, an artificial pacemaker may be placed to take over initiating the heartbeat. On the EKG, this will be seen as what's called a paced rhythm. Patients may be atrially paced, where you will see a pacing spike just before the P wave, or they may be ventricularly paced, where you see the pacing spike just before the QRS complex. As you may have noticed, the QRS complex in this case is shaped a bit differently. This is because the impulses to contract the ventricles are coming from within the ventricles rather than from the SA node or the AV node. This causes the action potentials to be conducted from myocyte to myocyte within the ventricles, which is a lot slower than when the signals are propagated by the bundle of His and the Purkinje fibers. So the ventricles are activated and contract over a greater period of time, causing the QRS complex to be wider than usual. The same phenomenon is also seen with ventricular arrhythmias, which we will discuss later in the video. Going back to paced rhythms, some patients may also be dual-chamber paced, where the pacing signals come from both the atria and the ventricles. In addition to initiating the heartbeat, the artificial pacemaker also determines the heart rate in these patients, which can be programmed at a specific number. In patients without a pacemaker, it's normal for the resting heart rate to fluctuate somewhere between 60 to 70 beats per minute. For example, it may wander from being 64 to 62 to 63 and so on. But in a patient with a pacemaker that has had its resting heart rate set to 70 beats per minute, the resting heart rate will always be exactly 70 beats per minute. Sometimes pacemakers can misbehave and cause the heart to beat too slowly, too quickly, or in an irregular rhythm. Pacemaker reps and cardiologists can wirelessly interrogate the pacemaker and make various changes to the settings, but until they arrive in the ED, something we can try is called a pacemaker magnet. Pacemakers have a reed switch inside that can be turned on or off by a magnetic field. So by placing the magnet over the patient's pacemaker, we can temporarily set the misbehaving pacemaker into its default mode, which will cause it to pace at a predetermined fixed rate. This rate will depend on the manufacturer, but it generally ranges from 70 to 100 beats per minute. These magnets are usually hanging around the code cart, by the charge nurse's desk, or in the dock box somewhere. Try looking for one the next time you're in the department. Now let's move on to our first irregular rhythm, atrial fibrillation. Also known as AFib, this is when the top two chambers of the heart or the atria beat in an irregular rhythm due to disorganized electrical currents. Instead of contracting and relaxing rhythmically, they spasm and quiver at over 300 to 600 times a minute. Remember that the heart normally beats at about 60 to 100 beats per minute. These disorganized and random impulses are caused by ectopic or automaticity foci that are in the atria. These are potential pacemaker cells that are capable of initiating a heartbeat in case the SA node fails. Normally, these cells are turned off, but can erroneously fire and cause the heart to beat in an irregular rhythm, such as in atrial fibrillation. Even though the atria is firing off at 300 to 600 times a minute, the heart sort of has a safety mechanism where the AV node limits the number of these impulses from being conducted down to the ventricles. Still, many of them are able to get by, causing the heart to beat at a rate that is quicker than normal, somewhere in the 100 to 170s range. This is called AFib with RVR, where RVR stands for Rapid Ventricular Response. On the EKG, this is what AFib will look like. Let's compare to normal sinus rhythm. In normal sinus rhythm, you can see the P waves that precede each heartbeat, but in AFib, you're not able to make out the individual P waves. Because the atria are quivering rather than squeezing rhythmically, all you see are these random squiggly lines called fibrillatory waves. This is the main characteristic of AFib on the EKG. AFib is described as being an irregularly irregular rhythm. If we look at just one heartbeat, there is no normal P wave, so it's considered to be irregular. While the AV node was doing its best to limit the number of impulses getting down to the ventricles, some were still able to get by. This happens at irregular intervals as shown by the varying spacing between the heartbeats. This is why AFib is described as being an irregularly irregular rhythm. The irregular heartbeat is occurring at irregular intervals. Patients can have what's called paroxysmal atrial fibrillation, where they are usually in a normal rhythm, but will suddenly jump in and out of AFib. For other patients, they could always be in AFib, and that would be their normal baseline. Some patients can feel themselves go in and out of AFib, and some patients don't have any symptoms at all. Now let's move on to atrial tachycardia. These are again caused by ectopic or automaticity foci that are located in the atria. There are two kinds of atrial tachycardia, unifocal atrial tachycardia and multifocal atrial tachycardia. As the name suggests, in unifocal atrial tachycardia, there is just one ectopic focus that is producing the abnormal action potentials that are causing the atria to beat too quickly. In multifocal atrial tachycardia, there are multiple ectopic foci in the atria that are producing the abnormal action potentials. On the EKG, unifocal atrial tachycardia is identifiable by its abnormal P wave morphology or the shape of the P wave. Let's compare it to the P wave of the sinus tachycardia and see if we can spot any differences. In this example, the P waves in unifocal atrial tachycardia are inverted or flipped upside down. This is because the impulses that are initiating the heartbeats are coming from somewhere else in the atria and not the SA node. Now let's check out what the EKG looks like for multifocal atrial tachycardia. With MAT or MFAT, we again see abnormal P wave morphology, but with more variations this time. Just about every P wave looks differently from one another since there are multiple areas that these ectopic beats are coming from. And because these beats are coming from different areas at different times, we also see varying PP, PR, and RR intervals, or varying spaces between the atrial beats and the ventricular beats. And here is another example of multifocal atrial tachycardia. Check out the P waves and how they keep changing their shape. Some are even inverted. And again, notice the varying distances between the heartbeats. Atrial tachycardia is typically seen as a transitional rhythm between frequent PACs and atrial fibrillation or atrial flutter. We will discuss PACs later in the video, but for now, let's move on to atrial flutter. In atrial flutter or A-flutter, there is a re-entry circuit in the atria that's causing the atria to beat in a rapid but organized rhythm. Like AFib and atrial tachycardia, ectopic foci again play a role, but whereas in AFib the electrical impulses were completely random and disorganized, In atrial flutter, the impulses are slightly more organized since they are in a closed loop. This causes the atria to beat around 300 times a minute, but similarly to atrial fibrillation, the AV node limits the number of these impulses that are conducted down to the ventricles. In atrial flutter, this reduction is typically done in a fixed ratio. So for example, in 2:1 AV conduction atrial flutter, every 2 atrial beats will result in 1 ventricular beat. Since the atria are beating around 300 times a minute, it will result in a ventricular rate of around 150. In 3:1 AV conduction atrial flutter, for every 3 atrial beats, you get 1 ventricular beat. With the atria beating at 300 times a minute, you end up with a ventricular rate of about 100 beats per minute. Due to the fixed conduction ratios, patients with atrial flutter will tend to have a ventricular rate that ranges from 75 to 150 beats per minute. The characteristic finding of atrial flutter on the EKG is called a sawtooth pattern. The flutter waves of the atria resemble the teeth of a saw, and you can count the number of them between the QRS complexes to determine the AV conduction ratio. When you're counting the flutter waves, you do have to be a bit careful as they can become buried in the QRS complexes. Take note how the atria are fluttering with fairly regular intervals, and because the AV conduction ratio is typically fixed, you end up with regular spacing between the QRS complexes as well. This, however, isn't always the case, and rarely you can have what's called atrial flutter with variable conduction. So this is A flutter since you can see the sawtooth flutter waves. But when you look at the spacing between the QRS complexes, they're a bit uneven at times. In this case, the number of flutter waves are varying between 2 and 3, so this would be an example of a variable of conduction atrial flutter. Again, these are pretty rare, and 2:1 atrial flutter is actually the most common. Let's look at how atrial flutter compares with atrial fibrillation. Which one of these would you say is atrial flutter? So the top one is atrial flutter as shown by its characteristic sawtooth pattern. Also, the spacing between the heartbeats are pretty regular. In atrial fibrillation, there are no discernible P waves and the spacing between the QRS complexes will be irregular. And now let's check out these two examples. I don't know about you, but they're looking pretty similar to me. So the top one is sinus tachycardia, and the way we can tell is because we can still identify the individual P waves. And although they're really small, you can still make out the PR segment as well as the Q wave portion of the QRS complex. The bottom strip is showing 2:1 atrial flutter, and if you look closely, you don't really have a PR segment, and you don't really see the Q wave portion of the QRS complex either. It's like they were cut off by the flutter waves. So I know that the differences between these two are very subtle and that they were difficult to distinguish, but that's what ED docs are having to deal with in real life on a daily basis. Is this sinus tachycardia or is this atrial flutter? Now let's move on to another irregular rhythm that could look very similar to these called SVT. SVT stands for supraventricular tachycardia, which is technically an umbrella term that encompasses any fast heart rate that is due to an impulse originating from above the ventricles. This includes rhythms such as AFib, atrial tachycardia, and A-flutter. But when people speak of SVT, they're most commonly referring to AV-NRT, or AV nodal reentrant tachycardia. I know that's a mouthful, but it's essentially a fast heart rate that's caused by an impulse that gets trapped in a closed loop within the AV node. Similar to how some patients can have paroxysmal atrial fibrillation, patients can have paroxysmal SVT or PSVT. This is when they're usually in a normal rhythm, but will suddenly jump in and out of SVT. So in about 10 to 35% of the general population, patients can have what's called a dual AV nodal physiology. This is when instead of just one pathway down the AV node, individuals will have two pathways that look like this with a fast pathway and a slow pathway. In patients with such a physiology, this is how the AV node normally works. The action potential from the SA node will come down, and when it gets down to the AV node, will split into the two pathways. One action potential will travel down the fast pathway, and the other action potential will travel down the slow pathway. The action potential that travels down the fast pathway will reach the other side first, and continue to propagate down the bundle of His onto the right and the left bundle branches and into the Purkinje fibers of the ventricles. But a part of it also goes backwards along the slow pathway until it's met by the action potential that split off earlier. These two action potentials cancel each other out, and we're back to where we started, ready for the next heartbeat. By the way, the fast pathway has a long refractory period, and the slow pathway has a short refractory period. As we will see in a minute, it's these variances in conduction speeds and refractory periods that can cause problems to arise. So for these patients who have a dual AV nodal physiology, when there's a premature beat, typically caused by an ectopic foci, that premature beat will closely follow the previous normal heartbeat. For the premature action potential, the fast pathway is closed since the normal action potential had just gone by and is still in its long refractory period. So the premature signal can only go down the slow pathway, which has already recovered from the short refractory period. By the time the premature action potential reaches the other side, the fast pathway has now recovered from its refractory period, and in addition to propagating down the rest of the conduction pathway, the premature action potential is able to go backwards along the fast pathway. It's able to get back to the initial splitting off point before the next normal heartbeat gets there, and is able to re-enter the slow pathway, creating a loop within the AV node. This is where the name AV nodal reentrant tachycardia comes from. A re-entry circuit inside the AV node causes an abnormally fast heart rate. While there are other types of AV NRT, this is the most common mechanism. Patients with SVT will typically have a heart rate of 150 to 250 beats per minute, which is a bit faster than sinus tachycardia or atrial fibrillation, as those tend to run about 100 to 150 beats per minute. On the EKG, SVT will not show any P waves as they become hidden by the QRS complexes. So all you end up seeing are QRS complexes followed by the T waves. When you have these supraventricular tachycardias, whether it's AV NRT, AFib, or A-flutter, you have what's called narrow QRS morphology or narrow QRS complexes. This is when the shape of the QRS complex appears skinny and pointy. This is because the impulses that are causing the heart to beat quickly are being originated from above the ventricles, somewhere in the atria. This means that the impulses activate the ventricles via the bundle of His and the Purkinje fibers. Since the bundle of His and the Purkinje fibers are made up of specialized cells that can conduct action potentials very quickly, this allows for a fast and synchronized contraction of the ventricles, resulting in skinny and pointy QRS complexes. Going back to SVT, their characteristic findings on the EKG were a fast heart rate, hidden P waves, and narrow QRS complexes. Using this criteria, let's see how the EKG of SVT compares to sinus tachycardia. So just by looking at the spacing between the heartbeats and not counting any boxes or the number of heartbeats, we can tell that they're both beating pretty quickly. So both of these EKGs are showing tachycardia. Now let's see if we can find any P waves. In SVT, you won't be able to see the P waves as they get buried by the QRS complexes. So you only end up seeing the T waves that are present between the QRS complexes. So hidden P waves for SVT. In sinus tachycardia, you still have P waves, although they're pretty much pressed up right against the T wave of the previous heartbeat. They kind of resemble humps on a camel's back. One way to remember sinus tachycardia is to picture a camel with two humps running really fast. So hidden P waves for SVT, but no hidden P waves for sinus tachycardia. Now let's look at the QRS complexes. They both appear to be skinny and pointy, making SVT and sinus tachycardia both examples of narrow complex tachycardias. So although subtle, we can see how SVT differs from sinus tachycardia on the EKG. The only way to get better at identifying different rhythms is by repetition, so let's check out a few more examples. Although the rate isn't shown, just by seeing all the heartbeats in this 10-second run, you can tell that the patient is quite tachycardic. There are actually 37 heartbeats shown, so when you multiply it by 6, you get 222, which is really fast. Going by the rate alone, this probably isn't sinus tachycardia. Remember, those tend to run from 100 to 150 beats per minute. Anyways, let's try to look for P waves on this thing. These may look like P waves, but they're actually T waves, meaning that the P waves are being buried by the QRS complexes. And when we check out the QRS complexes, they look skinny and pointy, making them narrow complexes. So based on our findings of tachycardia, hidden P waves, and narrow QRS complexes, this would be considered SVT. Let's do one more. So I counted 42 heartbeats in this one, which would mean a ventricular rate of about 252 beats per minute. That's even faster than the last EKG. Now let's zoom in and see if we can find some P waves. This looks more like the P wave is being buried by the QRS complexes, so I will say this is a T wave. So we move on to looking at the QRS complex, which appears skinny and pointy, making it a narrow QRS complex. So with these findings of being tachycardic, hidden P waves, and narrow QRS complexes, this one also meets the criteria for SVT. But this EKG actually isn't SVT. It's actually 1-to-1 AV conduction atrial flutter. So here's lead 2 for SVT and 1-to-1 atrial flutter. While these definitely look very similar, you might be able to identify the flutter waves on the bottom EKG. But don't be discouraged if you miss this. SVT and 1-to-1 atrial flutter are notoriously difficult to distinguish. Just to mess with you a bit more, here are a few more examples of SVT and 1-to-1 atrial flutter. It's crazy how similar SVT and atrial flutter can look like one another, and I promise I didn't mix these up. This is how I feel about SVT and atrial flutter right about now. So as we've seen so far, sinus tachycardia and 2-to-1 atrial flutter can look very similar, and SVT and 1-to-1 atrial flutter can look very similar. They're all examples of tachycardia that are originating from above the ventricles, and here are a few things we can do to better differentiate them. Sinus tachycardia will usually have a rate between 100 and 150 beats per minute. Physiologically, there's a limit to how fast a heart can beat while still in sinus rhythm, and that number is about 220 minus your age. So if you're 20 years old, the fastest your heart can beat while still in sinus rhythm is about 200 beats per minute. If you're 60 years old, that number drops down to about 160 beats per minute. Also, for someone that's in sinus tachycardia, their heart rate will tend to wander. For example, their rate of 150 may move around from being 150 to 152, 154, 151, and so on. For patients that are in 2-to-1 atrial flutter, for whatever reason, they tend to have a heart rate of 150 beats per minute, and their heart rate will be very steady, continuing to stay at exactly 150 beats per minute. When you see heart rates that are a bit quicker, ranging from 150s and into the 200s, begin to suspect SVT or 1-to-1 atrial flutter. When patients are this tachycardic, everything on the EKG becomes squished super close together, making differentiating SVT from atrial flutter even more difficult. What we can do in these cases is administer a medication called adenosine. Adenosine is an antiarrhythmic which works by blocking the AV node. Since all these abnormal impulses are coming from above the ventricles, if we block the AV node, we should be able to stop or slow these impulses from making their way down to the ventricles. So that's the idea behind adenosine. If a patient is in SVT, adenosine can actually convert them out of SVT and into normal sinus rhythm. Remember that SVT is most commonly referring to AV NRT when there's a closed circuit within the AV node. Adenosine basically resets the AV node, interrupting the closed circuit and allowing sinus rhythm to take over again. If the patient is in atrial flutter, adenosine won't convert them into sinus rhythm, but what it can do is by blocking the AV node, decrease the number of impulses that are making it down to the ventricles. This results in less QRS complexes, revealing the flutter waves and making them easier to see. So adenosine can be used as a diagnostic tool for atrial flutter and as a therapeutic agent for SVT. Here's another example of adenosine in action. So this looks like it could be 1-to-1 atrial flutter or SVT. When this patient was given adenosine, look what happened. We can clearly see flutter waves making this atrial flutter. In this example, V1 looks like it could be 1-to-1 or 2-to-1 atrial flutter or SVT. V2 looks like it could be 2-to-1 atrial flutter, and V5 looks like SVT. So basically, I don't have a clue what it could be. And here's what happened with adenosine. Again, we're able to see flutter waves making an atrial flutter. Last one for now, and in this example, we're able to see SVT get converted with adenosine into normal sinus rhythm. So hopefully that helped in being able to recognize the subtle differences between sinus tachycardia, atrial flutter, and SVT. I know I'm being really repetitive at this point, but to summarize once more the different kinds of supraventricular tachycardias, sinus tachycardia is when there are fast signals coming from the SA node. Atrial fibrillation is when there are random disorganized signals in the atria. Atrial flutter is when there's a closed loop circuit in the atria. AV NRT, or more commonly referred to as SVT, is when there's a closed loop circuit within the AV node. Let's move on to our next irregular rhythm, PACs, or premature atrial contractions. These are essentially extra heartbeats caused by atopic or automaticity foci in the atria. On the EKG, they're seen as an abnormal P wave followed by a normal appearing QRS complex. Following the extra heartbeat, there's a prolonged RR period as the SA node resets. The morphology or shape of the P wave in PACs are different from a normal P wave since they're being generated by an atopic foci and not the SA node as usual. Sometimes the premature P wave can overlap or be hidden in the T wave of the preceding heartbeat as shown in this example. PACs can happen occasionally, in repeating patterns, or in multiple runs. This EKG is showing a normal heartbeat, a PAC, a normal heartbeat, a PAC, and so on. You can also see that after each PAC, there is a prolonged RR interval as the SA node resets. As the PACs are occurring on the every second beat, this pattern is called bigeminy. If they occur on the every third beat, it's called trigeminy, and every fourth beat, quadrigeminy. Let's look at another example. So here's a normal P wave, another normal P wave, a premature abnormal P wave with a normal QRS complex, longer RR period, normal P wave, and a premature abnormal P wave with a normal QRS. Since the PACs are occurring on the every third beat, this would be an example of trigeminy. And here's how PACs compare to AFib. At a quick glance, they may appear to be similar since they both have irregular spacing between the heartbeats. But in PACs, you can still identify the P waves, whereas in AFib, you can't. PVCs, or premature ventricular contractions, are extra heartbeats that are caused by ectopic foci in the ventricles. This causes an EKG finding that looks like this. Because the impulses are being originated from the ventricles rather than down the bund of His and the Purkinje fibers, they are being conducted myocyte to myocyte. This causes the ventricles to depolarize over a longer period of time, causing a wide QRS complex. PVCs, like PACs, can occur occasionally in repeating patterns or in multiple runs. Let's first identify the PVCs. Now let's see how frequently they're occurring in comparison to a normal sinus heartbeat. Because the PVCs are occurring on every second beat, this would be bigeminy. In this example, you see PVC on every fourth beat, so this would be quadrigeminy. They can also occur in doublets like this, as well as triplets. So that was PACs and PVCs. Let's move on to ventricular tachycardia, or VTach. As the name suggests, it's a fast heartbeat that's caused by an irregular impulse originating from somewhere in the ventricles. It's most commonly caused by scar tissue in the myocardium that creates an abnormal re-entry pathway. The idea is that when a section of the heart becomes damaged and scarred as a result of a heart attack, cardiomyopathy, or other forms of heart disease, the particular area of the heart will have varying degrees of electrical conduction, allowing re-entry pathways to form. While this is the most common mechanism of ventricular tachycardia, it can also occur due to increased automaticity of ectopic foci in the ventricles. On the EKG, VTach will look something like this. The characteristic EKG finding of ventricular tachycardia are the broad or wide QRS complexes. Again, this is because the impulses are originating from within the ventricles and not being conducted via the His-Purkinje system. Also, P or T waves will not be visible in VTach. Now let's check out how VTach compares to some of the other rhythms we've seen so far. In ventricular tachycardia, we can see how the bases of the QRS complexes are much wider when compared with SVT or AVNRT. Remember that SVT had its impulses originating from above the ventricles, hence its narrow complexes. By the way, these are all examples of monomorphic VTach, which means that the shape of each beat is the same. This also tells us that the abnormal impulse is being generated from a single point in the ventricles. When there are abnormal impulses being generated from multiple sites in the ventricles, or you have varying sequences of ventricular activation, you will have what's called polymorphic ventricular tachycardia, where the shape of the beats are continuously changing. In lead 2, check out the shape of this heartbeat and see how it changes as the EKG progresses. Polymorphic VTach is less organized than monomorphic VTach and can more easily develop into a more dangerous rhythm called ventricular fibrillation, or VFib. Torsades at points, which is French for twisting of the peaks, is a specific form of polymorphic ventricular tachycardia, where on the EKG it looks like the QRS complexes get taller and shorter and taller and shorter. It's as if you had a long strip of monomorphic VTach and you twisted the ends of the paper in opposite directions, kind of like on a ribbon or a streamer. What you end up with is this football-shaped EKG where the QRS complexes are continuously changing. Like other forms of polymorphic VTach, torsades can develop into ventricular fibrillation, which could be life-threatening. Ventricular fibrillation is when disorganized electrical activity causes the ventricles to spasm and quiver instead of contracting rhythmically. It's just like an atrial fibrillation, except it's happening in the ventricles. Clinically, this is way worse since the ventricles are critical in actually performing the heart's main function of pumping blood. As there are no effective contractions, there is very little to zero cardiac output. So VFib is technically considered to be a cardiac arrest rhythm, basically the same as if the heart has stopped completely. Without cardiopulmonary resuscitation or CPR, VFib will generally result in death within 3 to 5 minutes. Some of the things that could cause the heart to go into VFib include ischemic heart disease, myocardial infarction, cardiomyopathy, tension pneumothorax, cardiac tamponade, electrolyte abnormality, cardiotoxic drugs, drowning, and trauma. The idea is that when the myocardium becomes hypoxic due to any of the reasons just mentioned, ectopic foci in the ventricles become irritated and begin firing off action potentials. Hypoxia is also thought to increase the re-entrance circuits, which would further exacerbate the problem. On the EKG, all you see are random squiggly lines or fibrillatory waves caused by the ventricles quivering and spasming. There are no P waves, QRS complexes, or T waves. Coarse VFib tends to respond better to defibrillation than fine VFib. You can see how fine VFib more closely resembles asystole than coarse VFib. Ventricular fibrillation can sometimes look similarly to polymorphic ventricular tachycardia. So here's an example of VFib, and here's an example of polymorphic VTach. Again, VFib and polymorphic VTach. While ventricular tachycardia and ventricular fibrillation are both unstable and dangerous rhythms, they are also both shockable rhythms. This means it's possible to electrically shock or defibrillate the patient and restore sinus rhythm. To illustrate what VFib looks like in real life, here's a short video. So here we're seeing the fibrillatory waves on the cardiac monitor. And here we can actually see the heart fibrillate or quiver and spasm instead of beating rhythmically. And here we're seeing the heart being defibrillated, where it's being shocked back into a normal rhythm. And on the monitor, we have return of a sinus rhythm. Asystole or flatlining tells us that there isn't any electrical activity occurring in the heart. Asystole is not a shockable rhythm, and although it can be treated with CPR, vasopressors, and by quickly identifying and treating the underlying cause, it generally does not have a very good prognosis. PEA, or pulseless electrical activity, is when you're still picking up electrical activity from the heart on the EKG, but no pulses are able to be detected. So while the heart's electrical system is still firing, the muscles aren't contracting or squeezing. It's another example of cardiac arrest. Similarly to asystole, PEA is not a shockable rhythm. So that's all of the rhythms we will talk about today, and we covered quite a bit. But wait, what about ventricular flutter? Ventricular flutter is considered to be one of the most indiscernible arrhythmias, existing only as a brief transitional stage between VTach and VFib. While there are still a lot of rhythms we haven't talked about today, hopefully this will serve as a good starting point. And now it's time for a surprise EKG rhythm quiz. So if you're ready, let's start with this one. Which rhythm do you see on this EKG? So this one is atrial flutter. The easiest way to tell is by being able to recognize a sawtooth pattern, which are the P waves that are firing off due to a closed loop circuit. What about this one? Which rhythm do you see? This one is atrial fibrillation. There is no obvious P waves, and the heartbeat is occurring at irregular intervals, making it an irregularly irregular rhythm. Okay, now let's check out this one. This one is normal sinus rhythm. You see a normal looking P wave at the beginning of the heartbeat, then a normal looking QRS complex, followed by a normal looking T wave. You also have regular spacing between the heartbeats, all of which makes it a totally normal rhythm. Let's try this one. This is an example of torsades at points, which is a type of polymorphic ventricular tachycardia. You see the peaks get smaller than bigger and smaller than bigger. The base of the QRS complexes are wide, and it's as if the EKG was twisted at the ends like a ribbon or a streamer. What about this one? This one is ventricular tachycardia, and more specifically monomorphic VTach. The base of the QRS complexes are wide, meaning it's a wide complex tachycardia, and the shape of the QRS all looks the same, making it a monomorphic VTach. This one is kind of tricky, but give it a shot. This is sinus tachycardia. The P waves are kind of clashing with the T waves of the previous heartbeats, but you can still see them. Again, picture a double-humped camel running fast. The QRS complexes are narrow, the spacing between the heartbeats are regular. What would you call this one? This is PVCs. The weirdly shaped QRS complexes have a wide base, and other than the PVCs, the heartbeats look normal. This one doesn't appear to be occurring at any particular intervals, so it will be an example of occasional PVCs. And last one. This one is SVT. The P waves are hidden, so all you see are QRS complexes and T waves. The QRS complexes are narrow, and the spacing is regular. And congrats! You passed the surprise EKG rhythm quiz. If you'd like more practice in identifying various EKGs, I'll leave links to a few websites in the descriptions. That's going to be it for part 2 of the Intro to EKG video. In part 3, we will finish going over how to interpret the EKG.